there's nothing that requires you to use the ARPA code. So
Right.
the workflow that's clinically appropriate remains in place.
Mhm.
Just that you have the benefit of claiming enhanced match if we meet that level of service. But how are you going to distinguish that on your end?
Okay, great question. Let me just go back for a minute because I forgot to start the recording. So we're going to record this session now going forward, presuming no one objects. If anybody would like to object to recording, please come off mic and say so, and we'll stop the recording. And then just to tee up the conversation for the recording purposes, currently we're talking about the fact that CMS just approved New Hampshire's SPA for crisis services. Okay, back to your question, Kelly. The coding that we're going to be looking at are the crisis intervention codes. So I think those are the per diem, the 15-minute unit. So just not the psychotherapy ones. And in terms of the crisis intervention ones, it is with the HT modifier. And the place of service code has to be a compliant place of service. So, for instance, the school setting, that's a compliant place of service. Doing it at your office is unlikely to be considered a compliant service location because that's considered more office-based at that point. The emergency department certainly won't be considered a compliant location. So we have identified the codes that will correctly map, the service codes that will correctly map with the HT modifier, the U9 modifier, and then the actual CBT code for the
So
claiming
all
purposes.
team-based, so all team-based community services are what you're going to target.
Basically, yes.
Okay, thank you.
You're welcome. Now, the one thing is if we can track towards setting up a unique code for that ARPA compliant episode, say it was a per diem code or like a half day and a full day, something like that. It's a bundled code at that point, which means if one person is providing part of the service at one point versus the other, that's okay because it's a bundled service at that point. It could yield benefits for the centers if we can end up doing this, because at that point you have more of a smoothed rate that is less tied to the actual widgets, the 15-minute units that you're providing and who's providing it. So in essence, if you're getting like right now, the HT rate at the per diem is approximately $1,200, I think, for a per diem, that rate would cover it even if 50% of the time the service was being delivered by a peer. Allie?
So will there be changes to the rapid response billing guidance
Yes.
that we were given? Okay, because I think in some of that there is an instruction about when we should use which codes.
Mhm.
And I think that when Patricia mentioned, the locations that were deemed more safe, like a school, I think the guidance says that only one clinician should go to that. So we were following that guidance. And now it sounds like you're saying that we could use a team in that instance, if I'm understanding it correctly.
I did not know that the one-person team was encouraged in the original billing guidance. I don't think we had put that in it, the 2021 version, that these safe locations, I think that evolved through the work done with the Dartmouth team and Brian Harvey, et cetera, that evolved as we kept looking at practice and how to improve practice. It didn't translate into changes in the billing guidance. So we will update it. But I think those getting into the nuances of the safe location is probably best not to be in the billing guidance.
I thought it was in the July 21 billing guidance around the schools.
It was. That was an early on thing before we started with Dartmouth.
It was. That's interesting.
Right, so there hasn't been an
I'm not
updated
recalling it,
guidance
and I wrote
document.
it.
There hasn't been an updated guidance document published, so that is the document that we're all or should be following.
Right. Okay. Sorry, I will look into that, perhaps even on this call. It's good to know. So one person, let's see. Okay,
Yeah, it's on
Anything-
page 9 of that document.
page 9, thank you. Okay, so let's see. 2-person team responds there. Yep. Oh, yes, because that one, it was a master's level, so it allowed master's is deployed 1 hour, provider bills, H20 for 4 units uses the HO modifier. So that would still be able to occur in the future. That won't change. It's just that if it's a 2-person, it would be the HT that would be used. It would be a master's and someone else, and that would then be ARPA compliant. Okay, so so that the billing guidance is just based on the fact that a 1-person team responded. It really wasn't built on based on the fact that on the programmatic side, that we had just, BMHS had decided that in those locations, it's okay for a 1-person, that it just really was about, is it 1-person or 2-person from the billing side? But thank you, guys. Okay, so on that SPA, the other thing we did is, so we have the ARPA compliant mobile crisis services. Then we have crisis stabilization services, which that's the catch-all for all of the non-ARPA compliant mobile crisis services. Anything you're doing in crisis response, that's happening like at your center. So if you have walk-ins, things like that, it would be the part of the plan that would cover sort of a modified approach to setting up a crisis stabilization center. So if you were looking at like a crisis stabilization site that was primarily staffed with peers, peer services are a covered service under this, so that could still be covered under the crisis stabilization. It would not be covered under the crisis stabilization center part of the state plan amendment. On the crisis stabilization center part of the state plan, we have 2 options, and I'll send you folks out the state plan, by the way, if you didn't already see it, because it's publicly available now. There's 2 options in the stabilization center space. One is basically your 23-hour model, right, where there's really not overnights happening, and overnight I know can be a misnomer, but there's not more than 24 hours at a time. So that type of model. And then there's an overnight type of model that can have up to 16 beds, can't go over 16 beds. So we've covered for the future in terms of understanding that we may have future needs to actually grow up to 16 bed crisis stabilization centers in New Hampshire. Was someone going to say something?
Yeah,
Go ahead. Okay, maybe it's a mistake. I'll go back. So those are the 2 options that we had. And what we ended up doing working with CMS is being able to modify the initial approach that we had taken to the staffing model. So some of you folks may recall that we had a full-time administrator position, a full-time clinical director, a full-time charge nurse. We had a combination of masters and bachelors and peers. And then I think I said we also had the clinical director, on-call or present physician, on-call access to a psychiatric consultant, et cetera. And they were, for most of those leadership positions, they were identified as full-time. What we reapproached CMS with is for FQRCs, FQHCs, right? Federally qualified health centers, yeah. Rural health clinics at CMHCs and hospital outpatient programs. For those 4 types of entities, if they were the ones operating a crisis stabilization center, then that leadership, those positions, those guiding positions could be essentially allocated based on the hours of operation that the center was actually operating on. If they were under if the centers were under the general oversight of the CEO or COO, or like their medical director, like 3 positions or something like that. So if the overarching infrastructure of the entity was going to have some oversight of the stabilization center, then you could have greater flexibility in what you actually needed to allocate for those higher level resources to your stabilization center. And the underlying threshold there is that you have to have the ability to, a licensed professional to do the assessment. You have to have the ability for basic medical needs, such as first aid, to be covered. Prescriber. You had to have access to a prescriber. So sort of that way. So we think it's going to give a lot more flexibility, particularly as some centers sort of need a glide path to going to 24 hours of operation. Like maybe we're going to start Monday through Fridays all day, then maybe we're going to go extended evening hours, then maybe we're going to add weekends. So it gives us a really nice glide path because it makes that senior leadership more proportionate to the overall hours of operation. So I'll pause there to see if anybody has a question with that. And I believe Maggie, your team, Patricia, your team, CLM. I just want to thank you folks because I know we had gotten on some calls together or some email threads where we sort of teased through what you folks were looking at in terms of your options. So I think we landed in a nice place, but also still given the state some assurity that if some other type of provider wanted to come in where we didn't feel they had the appropriate infrastructure to support the center, that we still had that baseline of infrastructure being actually built into the applicable center. Sound good? All right, great, thank you. So that was the first big update. The next update is just to give you folks a heads up that CMS also approved this week, I think it was Wednesday, the coding issue that we had regarding the supportive housing 1915I benefit. You may recall that one of the services was set up in our application, in our approved state plan, as a per diem service in our system. So we identified code, we built it into our MMIS system as a per diem, but our application had gone into CMS with it being identified as a service up to 150 hours. And so CMS came back and said, you can't use a code that is a per diem code if the max ceiling is 150 hours. And then, of course, you could get a prior authorization to exceed that. But they said no, so then we had to work with them on getting approval for a different code. We got that approval, so we're getting ready to release the guidance on that very soon now that we've got that clearance. That was the sort of one big thing we really had to get through. So that's just a brief update on that. And then the last update I have for you is that I am planning to retire from the department sometime before the end of the year. I haven't submitted the paperwork yet because I do have to still work after I retire from the state. I need my career 2.0, whatever that may be. So I am looking for that now, and will submit it. I don't think it will be all the way to the end of December 31st. My goal was anywhere from September to December. So Katya said that I might want to tell the CMHCs today so that you folks hear it from me. So thank you. Ready for picking up on that timely directed payment discussion? Okay. So Heather, Gagnon, Patricia, thank you both so much for your help in writing back. I'm sorry that I did not write back yet. I actually have had in my draft email box my feedback and everything. And about 2 days ago, I said, let's just wait till Friday because we'll see them there. So thank you for sending that information to me. I'm going to go into a slide where I've pared down what you guys had written and sort of put it in there so we can tease through it a little bit more with folks. Hopefully nobody minds. So what Heather and Patricia and Jen had come up with, Jen, I'm sorry I missed you on the first time of saying thank you for that. Had sort of started to organize the thinking of what we had talked about at first. So with respect to hospital DRF discharges, hang on a second, let me make sure this is big enough for folks. Is that big enough for you to read well now? Yes, okay, good, thank you. So hospital DRF discharges. So when the hospital or DRF requests for an intake appointment after the discharge, we would not want to consider that the first contact. This is what we had discussed to sort of align all the centers, regardless if you're a center becoming a CCBHC or not. We still are teasing through this, but I want to make sure I'm understanding where we left off with our discussion. It would not be considered the first contact, but a referral. Then for the same day, next day, if the person actually received the intake at that same day, next day, if that was actually conducted, that would qualify for both same day, next day, and timely access. I don't think I'm going to stop here. I suspect most people don't have a concern about that. Does that sound good to everybody? If the actual same day, next day wasn't an intake, that would qualify for both. Okay. Then the other option is the person was seen, but the intake is scheduled and then occurs within 30 days, right? So in that instance, again, sorry, I didn't mean to do that key. I meant to do this key. If that was the case, that sequence would qualify for both. Makes sense to everybody? Good approach? Okay. Now, go ahead,
How does that
Christopher.
qualify for same day, next day?
They were seen within that same day, next day period. And
Oh,
then
so-
the intake was
okay.
scheduled and occurred within 30 days.
All right. So seen wasn't an intake, but they had,
Right. Right. So the, and I have to put a little note here. Let's put a little asterisk. Because the asterisk is cannot be a crisis service. So if it's a crisis service, that's in fee for service, so it wouldn't count for the same day, next day. But it would still count as the triggering point towards the starting clock for the timely access.
Can you say more about that? So does it have to be coded as an intake, or can the crisis stabilization service or crisis service occur, and then
If-
that's the start point again?
If the person was seen same day or next day, but it was a crisis service that they received, so a service with the U9 modifier. So they were seen by the mobile crisis team, essentially. If they were seen by the mobile crisis team, because that service is in fee for service, it would not qualify for meeting the same day, next day directed payment. Because it's not in managed care. The service has to be a managed care covered service. But if they were seen and they got that crisis service or any other service, and then they got their intake within 30 days of that service, because we're considering that service the first contact, the first knock on the door, then it could qualify for the timely access to service within 30 days. Does that make sense, Steve?
It does. I mean, our model is that our acute services team sees all hospital discharges, so I'm just trying to get the workflow down. So as long as they see the person same day or next day, that restarts the clock for a 30-day intake.
Yes, you're it's kind of like you're coming in and out, like we can still hear you, but there's some muffling in your microphone.
Sorry, I have microphone issues. So our model is that our acute services team sees all hospital discharges. If they see somebody same day, next day with modifier, we then have 30 days for the intake.
As long as they're seen, right? If they're seen, if they get a crisis service or any service, it would still qualify to start the clock for the 30-day timely access.
Okay.
Patricia, did you have a follow-up? No. Okay. Lisa, were you going to say something?
Yeah, I was going to ask, since the mobile crisis service is not managed care, how are they going to calculate that being the start of the 30-day clock?
We calculate those things and we feed the data back to the managed care organizations, and that's how they know what payments to cut.
Great.
So we would see it in Medicaid data.
Thank
Allie,
you.
did you have a question? You're welcome.
I guess I'm just trying to understand, is this a change to directed payments overall? Because right now, crisis services do count for same day, next day.
They should not be counting for same day, next day. Because they're not
Kelly,
in managed care.
Kelly, I'm not losing my mind here, right? Like those count currently, right?
I thought they did. I put a note to go back and check all the guidance.
Yeah, it can be a crisis intervention service like by your clinical team, but if it's the crisis services that are in fee for service, that's what doesn't qualify or isn't supposed to be qualifying.
So we have situations though where these are not clients of ours, but they are in our catchment, and they're coming out of a DRF not connected to us, being referred to us. Those would go through our rapid response team because they're not connected to us yet. Only if it's a case where it's a patient who is already connected to us and assigned to a team would someone be doing the follow-up in their regular home program. So I feel like this is a big change from what is happening now. And I do feel like we are getting credit currently when the same day, next day is being done by rapid response and we're billing those crisis codes.
I'll have to connect back with our team in data analytics because they shouldn't have qualified because the actual service isn't in managed care. And it could just be that when we started the same day, next day, which remember, we started it way before we carved out crisis services and put them into fee for services for mobile crisis, right? We started that in 21, but the directed payment for next day, same day, next day started, I think like around 2018. So it could be that in updating each year, the folks that grabbed the metrics associated with identifying the directed payments weren't aware of that implication of moving crisis services into fee for service, moving some crisis services into fee for service.
This is Maureen, excuse me, this is Maureen from Nashua. We also do that. We have all our DRF and New Hampshire Hospital non-connected discharges go through our essentially our ES rapid response program. So this would create and I believe they've been being counted. And so this would represent a pretty big change to our workflow if we are going to have to now find a way to to have them going through a different department, like our intake department. So I'm going to go back and check our, information as well to confirm that they've been being counted, but this sounds new to us as well.
Okay, yeah, that would be great, Maureen. Thank you. And when you said it's your ES rapid response, do you mean it's your mobile crisis teams delivering it or somebody else?
All one department. Yeah, we call it ES. It's our MCRT clinicians also do rapid response. So and they're doing, I believe, crisis evals for people. I have to double check, but I believe they're doing crisis evals for people coming out of like DRF.
So if mobile crisis, if personnel are functioning as mobile crisis, that's when they should be billing with the U9 modifier. If they're not functioning as mobile crisis, they should not be using the U9 modifier.
Okay, so we have to get back with our team and just figure out what it is we are doing and see if this is a change for us or not, I guess.
And just to, go back and be clear, because I do have notes from earlier and I'm looking at the preprint and the conversations were, and the language is any service provided by the CMHP. So there were times where the distinction was they had to be managed care services, but in this situation, New Hampshire Hospital and other hospital-based designated receiving facilities, same day, next day, it's what it says is any service provided by the CMHP Council, but it is for MCO enrolled members. So yeah, we might all have a lot of housekeeping on this.
Yes, I don't immediately, even if this has been occurring in the past, I don't immediately think we need to worry about any kind of negative reconciliation impact. Because I do know the guidance had said any service for MCO covered members and stuff. And that's the thing is MCO covered members can still get fee for service services that are not paid by MCOs. But as soon as they're not paid by the MCOs, it's not an MCO service. I mean, it's not a managed care service. And it was really Henry who made that distinction in like the past year in having, as we're looking at some of these distinctions for the timely access so I think that it may have just been lost on individuals when we originally set up the directed payment for same day, next day, because crisis was all in managed care at that point. So.
Yeah, it's not, I do understand what you're saying, and the issue about the MCO does feel familiar to me. I just would say this. That service, regardless of whether it's billed under mobile crisis or not, appropriately, either way, let's just say, still is an advantage to the member.
Absolutely.
It's an advantage to the MCO. It's a cost containment. It prevents it achieves all the goals that the directed payment is targeted to achieve. So,
right.
Just putting that out there.
Right.
Thank you, Diana.
I agree with everything you just said. And there is a slight nuance for those who are becoming CCBHCs because because of how the PPS works, and then there's the special crisis rate. So the crisis services that are delivered, even if they're delivered by a mobile crisis team, if they are the non-ARPA compliant, just for those CCBHCs, we're moving that back into managed care because the non-ARPA compliant is covered by the PPS daily rate. So for those entities, we're not going to have this problem with same day, next day, because it's part of their PPT, right? If it is an ARPA compliant mobile crisis team delivered service, that will stay in fee for service. The department will pay, the CMHC will bill the department will pay the CMHC under fee for service basis. And then we'll do the reconciliation with the crisis, the special crisis rate for the CCBHCs. So that is all, that piece of the CCBHC, it will be sliced differently because of the payment model associated with them. So guidance is going to get a little complicated when we'll probably be doing guidance specific to the CCBHC so that it doesn't get confused with the guidance for the non-CCBHCs. I'll pause there if anybody has another question. Okay. Same but intake. Okay, so same, that's if you saw them same day, next day. Now, if the person was discharged, and this is an example from Manchester, thank you, shows up 20 days later. So what you're proposing is 0 days wait for timely access, no other incentive. And yes, I acknowledge we can't control when somebody comes in. The thing is this is the one that I think the department would have the largest challenge with accepting, because our intent of the same day, next day, and the timely access is for, the centers to really be trying to make those connections at critical stages of needs. So I don't know that will fly when I take it to leadership.
But if it matches the CMS authorization for what the directed payment is, how does it not match? The access directed payment says that you have to have an intake within 30
Right.
days of first contact. So if someone was discharged, no showed, or refused to set up an appointment, but then shows up, why should the center be penalized for that?
But
Right,
Jay,
and there's no request
we
for
haven't
service.
seen that. I haven't seen the template that got submitted. I've only seen the slide deck. It didn't say from first contact. It said from date of application. So if the
Right.
template says from date of application, then there's going to be some standing here because date of application is specified in the rule.
Right, agreed. So the date of application is when the person or guardian contacts you. So if they're just discharged, we're not getting that contact. Right? We're calling that, request from the hospital DRF as a referral, not a first contact.
Do you folks feel like there's any difference between if the person didn't show up for the same day, next day, or if the center wasn't able to deliver a same day, next day, like they weren't able to be available for a same day, next day? There wasn't an appointment.
I'm a little lost just before I answer that. In this scenario you're asking about, did this come
Yeah.
from a referral from the hospital or DRF, or was this the actual individual parent guardian making the request? Because if we go by our other definition, I need to know that in order to answer your question.
I think that those are two different scenarios. The one I was asking about is the DRF had made an appointment or had tried to make an appointment with the center for same day, next day. So you know
Right,
this
so-
person is coming out, you're
But
supposed
in
to
that
try to
case, that's a
meet with them.
referral. Yeah, that's a referral, then not a request. So the 0 days makes sense to me. I don't know about the no other incentive, but I think based on how we've defined same day, next day, I think that's also accurate.
So what happens right now? Someone's going to discharge. How do you folks know to have a same day, next day appointment with them?
You'd get a referral from
And
the
we make an
hospital.
appointment.
And you make an appointment. Now, do you
Or you have
100% of the
walk-in
time make
days
an
for that.
appointment?
Repeat
100%
that,
we
Diane.
do we 100% make an appointment or give them that walk-in access for same day, next day?
Sometimes we schedule before they're discharged and see them before the discharge.
Right. Is there any times where a center can't make that appointment who doesn't have the walk-in hours available the next day?
Speaking for us, I can't think of a scenario where that would be the case. Just, it's
Okay.
too important and we just do it. It's our practice, right?
Yeah, same here.
Okay.
And maybe like Kelly said, we have to just wait and see more detail, but I do not recall hearing in any other or seeing in the slides that eligibility for the timely access incentive was contingent on meeting the requirement for same day, next day.
Eligibility for what was can you say that again? I'm
I've
sorry.
not seen, I don't think I've seen in your earlier slide, so maybe Kelly's correct. We have to see the detail from CMS.
She's right about
that-
the date of application. Yeah.
That's not what I was saying. Was
I'm sorry.
that
Go ahead.
that the access directed payment is not contingent upon achieving the same day, next day
It's not.
directed payment.
Yeah, it's not contingent upon that.
So then to say that this scenario in this bullet wouldn't qualify for the intake access directed payment doesn't.
I wasn't done updating it from what we were talking about. So if they were discharged, they don't show up for a same day, next day. The first next contact that they make, first next contact made, and I'm just saying to apply for services, starts the clock for the intake within the 30 days for timely access. So this would qualify for, based on what I'm hearing here, for timely access, but not for same day, next day. So am I accurately hearing what folks are suggesting we have as the approach?
I'm hoping somebody else says no, but in my mind, that's not what we were saying, but I could be wrong because I'm getting a little confused. I thought we were saying it qualifies for both essentially, but maybe I'm wrong.
Well, same
Well,
day,
no,
next day is
in this case
specific.
that she's showing us, she's clearly saying that they didn't show up for the same day, next day, so they don't qualify for same day, next day. But they had an appointment within 30 days. And that qualified for timely access.
Yeah, I think that's right.
Correct.
Correct.
So the one thing I would say is if they had an appointment within 30 days, of the discharge. I thought you were including that potential, but what I think I'm hearing is if they didn't show up, like we tried, like most of you, I think everybody said like probably 100% of the time, we've got at least the same day next day or walk-in hours we've given them for within the same day next day, right? So for whatever reason, the person doesn't show up either for that appointment or for same day next day, clock hasn't started for timely access because they haven't applied, right? The first next contact they made, what they make, whether it's a phone call and say, hey, I'd like to come in for services, or they just show up in your building, that starts the clock. Then you have 30 days for them to have the intake from that starting date.
That's correct, because if you match with CCBHC, you're triaging that contact, right? So you're defining whether or not it's a routine or if they need crisis services. So that's important to just keep in mind too. That applying for services, you still have to do the triage and risk assessment.
So do we feel like we have captured all of the potential scenarios associated with the hospital discharge?
Yes, Diana, would it be possible for you to just add like a little asterisk that says what Heather just said? Because for at least two of the centers, pretty soon, we're going to need to distinguish that triage issue. And I think it would be important, and it may be important for others who are going in that direction.
Is that what you mean, Patricia?
I think if we could add, and I'm gonna look to Heather to correct me, but I think if we could just add, if it says triage, which includes risk assessment, because I think that that's a critical requirement.
Yeah, agreed. Thanks, Patricia.
Great, thank you so much. Wait a second. I'm still getting over COVID. Okay, so then Heather, the Manchester team had this request for service call, not hospital DRF discharge. So just a generic one that is not associated with the discharge. So for the CCBHC, you record the call, provide risk assessment patient or guardian. This starts the clock in alignment with CCBHC. That makes sense to me. Now, for individuals, for CMHCs that are not CCBHCs, if it's a phone call that the person is making, we want it to count if it's the actual person or their guardian, right? Not some other entity making the referral.
Correct.
Is that what
Correct.
I
Correct.
think folks were saying? Okay.
Yeah.
Now, the question I have here is open access intake is not available Monday through Friday, like all business hours, correct?
Correct.
Does any center have it for all business hours? Okay, so I think our preference would be that if it is the individual or the guardian making the call, and to make sure we have sort of a uniform approach, that should start the clock, regardless if you have open access or not. I think I recall most centers are documenting that the person made that contact, and you're either providing them an appointment to come in or you're telling them they have open access. Now, Chris, I think you had said that your open access program, you're not taking that information on the call, you're just telling them to come in during the open access, but that you could be able to document the calls if we need to for this purpose. Was that correct?
Correct.
Okay. Does anybody have a concern with that phone call being the starting point to making the application?
Yes.
Not here.
Because I always would have.
Okay.
Yeah. Usually.
Comes into open access or receives an intake appointment within 30 days from call. Okay. If they are walking into open access, that all is alignment. So that would qualify. Now, the next group that we sort of need to get into here is finishing the discussion on the community reentry. And that is because the goal there is for a service to be delivered pre-discharge, but again, that service itself will not be, it will be under managed care, the service itself, so it can count as a trigger, but the full intake we recognize needs to happen after their release for the directed payment because unfortunately of our budget neutrality issues that we have. So here, ideally, we're looking at hopefully a two-step process. Pre-release service. I'm just calling it a service for right now because what we are looking at, and this is part of why I needed to continue the conversation here, is we're looking at the first service being the 90791 psych eval. Are there any centers who are performing the 90791 with less than a master's level? Everyone's at least using a master's level? If this was a two-step process where the balance of the intake would occur post-release, and you had first billed the 90791, what would you be billing post-release to complete the intake? Would it be one of the 99200s or like a 90792?
I'm sorry, can you clarify? Are you saying that we have to do the 791? That has to be the code that we do when the person's incarcerated?
No, that's just the one that we thought made sense. So we calculated our budget neutrality estimate based on this max dollar amount for 90791. So it could be a different code. So like thank you, Jay. So if you were to send through telehealth, a bachelor's level person to start the process, what code would you use? Because that's what I need to figure out, which codes we actually want to be able to identify for the community reentry program.
So
Um,
Diana, I think that probably if it's an extended, and people can chime in when we meet again, I think if it's an extended intake, it probably goes to psychotherapy, but it will depend on who the provider is. So for example, if the individual for some reason has Medicare and the doctor has to be the first person doing the appointment, then it could default to a 99. And in fact, even the first visit could default potentially to a 99 series code.
Okay.
Yeah, I
So-
thought we were gonna have to figure out first though what in the world they're doing initially to know what we should be maybe potentially billing or coding. Because we don't even know what that person's gonna be providing. We talked about ANSA, we had talked about some other things, but I think establishing that is gonna be key to then knowing what we do.
That's exactly where my head is. I don't know. I don't know the purpose or what it is they're doing to know what it should be coded as.
So what we're thinking, so we are looking for the intake process to begin pre-release, but we also want to be cognizant of the fact that there's a sizable directed payment associated with if it's finished within 30 days after they get out. So we want the connection to start pre-release, but the intake process to finish post-release. What that looks like is what we're leaning into you folks with to share with us. How would you like it to look like? It does not have to be a case management service because, of course, you can't provide case management until you've got through your intake process and you've got your ISP, right? You have to determine medical necessity to be able to provide case management services. So we know it's not going to be a case management service. So let's pick up. Go ahead.
I just have a quick question. I had thought that last time we met that you had said that there was going to be basically an exception so that you could provide the case management without the treatment plan, which is why I thought we had this whole discussion of how we wanted to align the CMHCs because we had the ability to bill case management without the treatment plan with this.
So we were tracking that way, Christine, and we could still conceivably do that with the waiver, like we just put in the guidance, right, that we were waiving that requirement. We could still go that approach. It would not be the monthly case management. It would be like the per diem version of it. We could certainly still do that. We really are just looking to the CMHCs to see how do you best envision this two-step process to happen. And if the first step is you're going to put in a case manager to maybe start taking some history from the person or something, that's completely fine. But I want to get that from you folks. So if we want to have like a little mini work group set up for that, we can do that, or we can just do this next Friday. Mini work group or next Friday, what do folks think?
I vote for next Friday. So,
Okay.
but
All right. So that's
I don't want to speak for everybody, however.
Yeah. Okay. So that's what we will continue the conversation. Thank you all so much. Great work. I appreciate you all. Thank you. Have a good weekend. Bye.